Surgical interventions have been considered curative in patients with early-stage hepatic malignancies. Various interventional radiology techniques are used as preoperative adjuvant therapies to enhance long-term survival. Those techniques aim at either reducing tumor size, increasing the volume of future liver remnant, or both. Those techniques include preoperative TACE, portal vein embolization, radiation lobectomy, and hepatic venous deprivation. Today we'll be speaking about these techniques. Preoperative TACE can contribute to tumor shrinkage in cases of HCC and colorectal liver metastasis, thus achieving the following results. Unresectable tumors can be transformed to resectable tumors. R0 resection rate improves and the possibility of recurrence decreases. Residual liver volume significantly increases, leading to a significant improvement in the 5-year survival. Unfortunately, no consensus has been reached regarding the influence of preoperative TACE on the prognosis of patients with HCC. It has the advantage of treating small satellite nodules that are commonly associated with HCC that cannot be excised by surgical resection. However, it doesn't come without complications such as perihepatic adhesions in cases of exophytic large lesions, increased risk of liver decompensation, and delay of surgical resection, which can turn some tumors to unresectable. Most of the studies that showed beneficial results of TACE were done on large tumors larger than 5 or 8 centimeters, while the studies that showed lack of benefit were in patients with tumors smaller than 5 centimeters. Complete tumor necrosis evidenced by complete lipidol uptake after TACE is linked to better outcomes. However, this is achieved in only a minority of patients. So, careful patient selection for preoperative TACE is essential, and routine use in all resectable HCC cases is not recommended. On the other hand, preoperative TACE, mainly drug-eluting bait TACE, can be done in colorectal liver metastasis, and it can prolong recurrence-free survival in these patients with high risk of recurrence, and it is a feasible option to fill the gap between systemic therapy and hepatectomy. This is a case of preoperative TACE done at our university, courtesy of Professor Dr. Muhammad Shafi. These are the pre-TACE CT images showing a large HCC lesion. And these are the axial and the coronal post-TACE CT images showing marked size regression of the lesion. These are the intraoperative images, and this is the resected tumor and the post-operative CT as we can see it here. Next, we move on to the techniques that promote future liver remnant hypertrophy. The future liver remnant is an indicator of the ability to maintain sufficient post-resection hepatic function. Patients with inadequate future liver remnant are at risk for post-hepatectomy liver failure, and the patients who have inadequate future liver remnant volume and are amenable to undergoing surgical resection are candidates for future liver remnant hypertrophy techniques. So, as my colleague Marwan stated, the target future liver remnant is more than 20% in patients with normal underlying hepatic function, and it should be more than 30% in patients with hepatic steatosis and substantial exposure to hepatotoxic chemotherapeutic agents, while it should exceed 40% in patients with cirrhosis with compromised hepatic function. Not only the volume is important, but also quality of the hepatic parenchyma is of equal importance. It can be assessed using MR elastography in fibrosis and chemical shift encoded MRI with proton density weighted fab fraction sequences in non-alcoholic fatty liver disease. Also, quantitative assessment of preoperative liver function can be performed using technetium-99 mebrofanin hepatobiliary scintigraphy. Portal vein embolization can be done to induce hypertrophy of the future liver remnant, and it works by occluding the portal vein branches to the tumor-bearing lobe and shunting the blood towards the contralateral lobe, which will be the future liver remnant. Absolute contraindications include patients with clinically significant portal hypertension, that is hepatic venous pressure gradient more than 12 millimeters mercury. Relative contraindications include tumor extension to the future liver remnant, extrahepatic metastatic disease, extensive portal vein tumor thrombosis, because most of the portal flow is diverted and there is high risk of non-target embolization, and biliary obstruction in the future liver remnant because the obstruction can impair liver regeneration. Embolization can be done either through an ipsilateral or a contralateral approach. In ipsilateral approach, we use a reverse curve catheter, while the contralateral approach is technically easier. However, it carries the risk of potential injury to the future liver remnant. Incomplete embolization can result in the formation of portal collateral vessels, which can limit the hypertrophy of the future liver remnant segments. Embolic agents include coils, MBCA and lipidol, ethanol, microparticles such as PVA, absorbable gelatin sponge, and foams including polydecanol and STS. This is a diagram showing the technique of portal vein embolization through a right lobe approach using a reverse curve catheter with the eventual hypertrophy of the left lobe. And this is a table showing the commonly used agents for portal vein embolization with their mechanism of action and benefits and drawbacks. A systematic review of nearly 1,800 patients undergoing portal vein embolization showed high technical and clinical success rates of 99% and 96% respectively. However, the resection rate is lower in cirrhotic patients undergoing portal vein embolization at only 70%. Failure to perform surgery can either be due to insufficient hypertrophy after embolization or tumor progression. The portal vein embolization can provide significant contralateral growth in a relatively short time of 6 to 8 weeks. Sequential TACE before or after embolization can improve the regeneration capacity of the liver parenchyma and reduce the risk of post-portal vein embolization tumor progression. This is a case of portal vein embolization using STS. This is our initial portogram showing preferential flow of blood into the right portal venous system. Then a balloon was introduced through the sheath and balloon occlusion was done. And this is a right portogram with injection of contrast through the sheath. And this is a left portogram with injection of contrast through the balloon catheter itself. Next, embolization was done using STS through the sheath. Finally, we can see our final portogram showing increased flow of blood into the left portal venous system. This is another case of portal venous embolization using histoacryl or glue. This is our initial portogram, and this is using a reverse curve catheter with a microcatheter inside it to inject the glue. And this is the injected glue in different branches of the right portal vein, and our post-embolization portogram showing the flow into the left portal venous system. Next, we move on to Y90 radiation lobectomy. It works by inducing fibrosis in the radiated hepatic lobe, and this slowly diverts the portal venous flow towards the contralateral lobe, promoting future liver remnant hypertrophy. Ideal hypertrophy is achieved at 6 to 9 months after the procedure, and for atrophy to occur, the non-tumor hepatic parenchyma should receive a dose higher than 88 grays with glass microspheres. This is an MRI image showing an HCC at segment 5 with associated malignant portal vein thrombus. This is a digital subtraction angiography done during the TARE procedure, and this is an MRI image done 3 months post-embolization, showing partial response within the tumor with inflammatory changes within the right hepatic lobe and mild hypertrophy of the left hepatic lobe. This is an MRI image done 9 months post-embolization, showing complete response within the tumor, atrophic changes of the right lobe, and marked hypertrophy of the left lobe. Despite the slower growth rate, the eventual future liver remnant augmentation achieved with radiation lobectomy is comparable to portal vein embolization. It has the advantages of decreasing the risk of tumor growth and post-resection recurrence. It also allows evaluation of tumor response to TARE, which can predict the biological characteristics and risk of recurrence and metastasis of the tumor, or what is called the biological test of time. There is a newly introduced concept of modified radiation lobectomy. It adds radiation segmentectomy to radiation lobectomy. Radiation segmentectomy is selection of an ablative dose higher than 190 grays to the tumor harboring segments while sparing the normal hepatic parenchyma. It has transitioned radioembolization from a salvage treatment to an option with curative intent in a select group of patients. This can be done by one of two approaches, the segmental plus lobar approach or the double segmental approach. This is a diagram showing the segmental plus lobar approach, where we inject an ablative dose into the segments harboring the tumor. Next, we inject a standard dose into the right hepatic lobe, and we can see the final effect here. And this is a diagram showing the double segmental approach, where the ablative dose is injected into the segments harboring the tumor, and next, a standard dose is injected into the rest of the segments of the right lobe. Finally, hepatic venous deprivation. It means adding hepatic vein embolization to portal vein embolization to promote the incremental growth in future liver resection. Embolic agents used include glue, coils, vascular plugs, alone or in combination. The 2 centimeters of the hepatic vein before the confluence with the IVC are not embolized to allow clamping of the hepatic vein during the resection. Hepatic venous deprivation compared with portal vein embolization alone provides a significantly higher growth rate and significantly greater future liver resection hypertrophy. And this is a diagram showing the combination of the portal vein embolization with embolic plug in the hepatic venous system. And this is a case where initially portal vein embolization was done, followed by embolization of the right hepatic vein using a vascular plug and coils. This is a table showing the benefits and drawbacks of the procedures done to promote future liver remnant hypertrophy. Thank you.
Thank you, Dr. Amr.
Thank you.
Any question for Dr. Amr?
Thank you.
Thank you. دلوقتي